Welcome to the GI Hepatology Academy presented by Harvard Medical School. My name is Dr. Thomas Lamont, and you are tuned in to the live session called Recent Advances in GI Endoscopy, What the Primary Care Physician Needs to Know with Dr. Ram Chaitani. Dr. Chaitani is the Director of Interventional Gastroenterology and Endoscopy at Beth Israel Deaconess Medical Center. He's an Assistant Professor of Medicine at Harvard Medical School. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout the presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Ram.
Thank you. Good afternoon, everybody, or good morning, wherever you are in the world. My topic today is to talk about recent advances in GI endoscopy, what the primary care physician needs to know. And this is a journey starting from the esophagus and ending in the rectum of the GI tract. And I would like to go over in the next 45 minutes or so all the recent or the most important recent advances that have taken place in the area field and how they may impact the practice that most primary care physicians have. So let's start with the first slide. Oh, I'm sorry. Yeah. So sorry about that. So the first area I would like to focus on is the esophagus. And in the esophagus, there have been tremendous new technology development and understanding of Barrett's esophagus. And in addition, I'd like to talk a little bit about what's new in benign stricture management and fistula management. And lastly, I may mention a little bit about endoscopic GERD therapies. When we talk about the imaging of Barrett's, what's really changed our ability to image is the availability of high definition imaging and narrowband imaging. But the most recent advances that are going to make an impact is the ability to do confocal microscopy at the same time that you're doing your endoscopy. So what this means is that you're able to look almost at the microscopic level, as I'm going to show you, and define where dysplasia may be or dysplastic cells may be. Beyond this, one of the things we are investigating is spectroscopy, and we recently published our data on the very, very early use of a spectroscopy probe used in the esophagus to detect dysplasia in Barrett's. And this probe just rotates around in small motions and can detect quite accurately where dysplastic cells may be, which are not visible to the naked eye. So I think there's a tremendous possibility with spectroscopy in the future, but we still have some ways to go there. Here is the example of the endocytoscopic system. There are two types of systems that are available. One made by Pentax is a scope which has the cytoscope within it, while the other one is a probe-based system developed by Monarchia Technologies, which can go through a scope, and you can have any scope, and it can come on the tissue and highlight in a very high magnification the cellular structure. So here's an example of confocal microscopy being used in Barrett's, and this is just straightforward non-dysplastic Barrett's. And if you can see the H&E staining, you can see the dark mucin in goblet cells, the columnar-lined epithelium, and the capillaries of regular shape. And you can see in the confocal microscopy images how well it matches with the H&E staining that is seen. Compare that with Barrett's with increased number of glands, irregular glandular forms, high dark contrast in surrounding structures and veliform structures architecture. This is Barrett's with dysplasia. And if we move to an image of Barrett's with adenocarcinoma, again, compare the H&E staining on the upper left corner with the confocal microscopy images showing completely disorganized epithelium, loss of microstructures, leakage of vessels, and an abrupt change to what's called the black cell. And this is a very, very accurate delineation compared to what the pathologic findings are in this patient. Now, let's move on to treatment of Barrett's, and that's where some of the most exciting advances in gastroenterology have been made in the last 5 or 6 years. So just to give an analogy, if you think about Barrett's esophagus, we know that Barrett's, there is about a 0.5% per patient per year change towards adenocarcinoma. And if someone has high-grade dysplasia, it increases significantly more than that. When you compare that to colonic polyps, indeed it's almost the same rate, 0.5% per patient per year turning over to adenocarcinoma. But the way we manage polyps is to remove these polyps. But the way we manage Barrett's is that we do surveillance, and we periodically follow these patients, rebiopsy when there can be a significant biopsy sampling error, but that's the way treatment for Barrett's so far has been. Now, the reason for that is that, first of all, Barrett's is not as common. Esophageal cancer is not as common, and if you compare with colon cancer, there are about 10 times more cases of colonic cancer compared to esophageal cancer. But when you look at the 5-year survival, that's where the impact really comes. Looking at the 5-year survival of esophageal cancer, it's only 8 to 15% compared to 66 to 90% for colonic cancer. So this is probably one of the most important studies published in surveillance of Barrett's. And this was by Pratik Sharma, where he found 1,300 patients with the first ever diagnosis of Barrett's were taken. And they followed 618 of these patients who had no dysplasia to see what happened to these patients. And what they found was that over a mean follow-up of 4.12 years, adenocarcinoma developed in 12, that's 2%, high-grade dysplasia in 3.6% patients, 16% of the patients developed low-grade dysplasia, and the rest of them continued as non-dysplastics. And that's where the number that comes, the 0.5% per year change towards cancer, comes from this landmark study. Now, having said that, I must preface it by saying that more of the newer data, which has come out in the last 2 years, suggests that the incidence of cancer in Barrett's may actually be less than this, and it may be closer to probably 2, instead of 0.5% per year, it's more like 0.2% per year, or maybe even a little less for short segment Barrett's. So perhaps it's not as much as this, but still, if you think long term, there is still at least a 10-fold increase chance of developing esophageal cancer if you have Barrett's compared to if you don't have Barrett's. So the question is, why don't we get rid of Barrett's? And the reason for that is, till this point, all therapies that were there for Barrett's were either incomplete, like the argon plasma coagulation or multipolar electrocoagulation or heater probe, or they were too dangerous. They would cause major complications like lasers and photodynamic therapy. Till most recently, when the first time a method came which is very thorough and very complete in its ablation, but at the same time is very safe, and that was radiofrequency ablation. And recently we are seeing more stuff come on cryoablation, which is freezing. So one is burning the tissue, the other one is freezing the tissue, and the last two over here seem to be very effective and quite safe methodologies. So the question comes, who do we ablate? And I think it's very easy if someone's not a surgical candidate. If someone's not a surgical candidate, yes, we don't have any other option but to ablate. But if someone is a good surgical candidate, we have to be quite careful and to select patients that have a low incidence of developing esophageal cancer. For example, very focal high-grade dysplasia, or patients with flat high-grade dysplasia in a localized area. And these would be good candidates to undergo radiofrequency ablation. While if you have nodular high-grade dysplasia or multifocal diffuse high-grade dysplasia, I think we have to be more careful. Now, I'm a big believer that low-grade dysplasia is one of the best indications for ablation, because for these patients, surgery is not an option at all. It's very, very invasive, and morbid. On the other hand, most of these patients get extremely nervous once they know that they have low-grade dysplasia, and we don't have anything good except very, very rapid surveillance every 6 months or so, high-dose PPIs to follow these. So I believe that would be a good indication for radiofrequency ablation. Also, the big question that comes is, what about non-dysplastic Barrett's? And there's a tremendous amount of research, including the one that we have done, looking at that and to follow these patients to see if it makes economic sense to do ablation for non-dysplastic Barrett's. And at this point, I think the jury is still out. I think we still need more data, long-term follow-up to see if we can, by ablating non-dysplastic Barrett's, can we be cost-effective? And I think that will be coming in the next few years. So how does ablation works? In ablation, the area that is ablated is up to the muscularis mucosa. We don't go into the submucosa and hence don't develop scarring and stricture formation that would be seen if we hit the submucosa. So in this diagram, muscularis mucosa is up to where the ablation takes place, and it's done very easily with a computer-generated module that delivers the current. So it's very carefully calibrated, and it's a circumferential ablation with the 360 device, as I'm going to show you over here. And this is mounted on a balloon. The balloon inflates in the lower part of the esophagus, and the current is delivered, and literally within 2 seconds or 3 seconds, the entire area is ablated. We also have a Halo 90 device which can go in a focal ablation for short segment Barrett's. We can put this right on a very, very short area, a small island, and ablate it in a postage stamp fashion. Here is an example of the Barrett's esophagus in the left slide, immediately post-ablation in the middle, and then at 1 year on the right, you can see the squamous epithelium completely repopulating that Barrett's mucosa. Here is the example of a Halo 90 device used to apply it in a focal area of Barrett's esophagus, as seen over here. And this was our study, the first study that looked at non-dysplastic Barrett's. And in this, even with one placement of radiofrequency ablation, at 1 year we were able to achieve 70% clearance of all intestinal metaplasia. Well, to us 70% doesn't sound very good. So what we did was that when we followed these patients, in the patients that had remaining Barrett's, we re-ablated them with a second ablation, and then followed these patients. And in this group, at 2.5 years, we had complete clearance of intestinal metaplasia in 98.4% of patients. There were over 1,000 biopsy specimens collected in this follow-up. There were no strictures, no buried glands. In fact, there were no complications in the entire study of about 61 patients. So very, very impressive results. And even if one biopsy was positive, we would call it a failure. So very impressive, simple method. But really, one of the most landmark studies that came out was the New England Journal study that came a few years back in 2009, where Nick Shaheen, in a multi-center fashion, looked at using Barrett's ablation or radiofrequency ablation for dysplastic Barrett's, both low-grade and high-grade dysplasia. And this study clearly showed the utility of this technology. And if you look at the last bar in this was in patients who underwent radiofrequency ablation compared to controls. In radiofrequency ablation, almost 90% of patients were completely free of all high-grade dysplasia, while only 19% in the control group or a sham group, which they did. Even more impressive is this slide. This is when you followed these patients, the ones that had the ablation versus the ones that did not have the ablation. If you look at the control group in the third bar chart, you see that 19% of the control group developed cancer, while only 2% developed cancer in the patients who had the ablation. So based on this, we have really come to the conclusion that the standard of care has changed from surgery to radiofrequency ablation for patients who have high-grade dysplasia in Barrett's esophagus that are not multifocal and not nodular. So this must be considered in the armamentarium. So,
Ron, which type of patient should primary care doctors send to you or another gastroenterologist for this sort of advanced technology?
Sure. I think like I mentioned, patients with high-grade dysplasia are clearly the ones that should be sent. Patients who have nodular single focus high-grade dysplasia also we can treat by some of the other techniques I'm going to demonstrate called endoscopic mucosal resection. But patients who have cancer clearly are not the ones appropriate for this type of treatment. But also what was shown in several other studies that I haven't described is that abnormal genetic markers are also eliminated once we do this Barretts radiofrequency ablation. And there is preservation of the esophageal function, excellent safety profile, and we are investigating the use of this technology for other etiologies, other entities like GAVE or radiation proctitis, and for hemostasis. Okay, let's move on to benign stricture management in the esophagus. And one of the things that came about is the removable stents. Stents were previously just naked meshes that we would put into for malignancies. Subsequently, they evolved into coated or covered stents. And the beauty of these covered stents is that they can be placed in strictures for a period of time up to 3 to 6 months. And these are used not just in the esophagus, but can be used in the colon, can be used in the duodenum, and can be used in the biliary tree. But many of these have the ability to be pulled out after a period of time. So we have been placing them for benign strictures, and especially for patients who have a tracheoesophageal fistula. By putting these covered stents, we can coat that fistula and allow it to heal, and the patient can still swallow. The next technique that we are doing now quite routinely is needle knife stricturoplasty. So just like a surgeon goes in and cuts the stricture open, we can now endoscopically go in and with a needle, as I'm going to show you, cut the stricture open and relieve the obstruction. And then there's an evolution for achalasia, a new technique which you're going to hear much more about, called endoscopic myotomy. It's also called POEM, or per-oral endoscopic myotomy, to treat achalasia endoscopically. And it's rapidly gaining steam, and in fact, the studies are showing to be even better than laparoscopic myotomy. These are some of the stents I was talking about. These are the removable stents. They have loops at their ends. You can place these. They have an anti-migration design, and these may be pulled out after 3 months or 4 months and sometimes 6 months to relieve or permanently cure that stricture. Here is an example of how we do a stricturoplasty, and this is a patient who has a very high-grade benign esophageal stricture. This was a post-op stricture, and this is being treated by one of my associates, Dr. Lee, with incision therapy using a needle knife to open it up. And it's fairly straightforward, and actually, even though it's quite dramatic, it's quite safe to do. Let's move on to the stomach. We're slowly making our progress, Dr. Lamont.
Good.
So in the stomach, I'm going to talk about advances in gastric endoscopy. And one of the videos that I'm not able to show is by Dr. Ono, and this will be on the website so you can view it. But the technique of endoscopic submucosal dissection. And this technique is used to remove these early gastric cancers without surgery. And what they do is they inject saline underneath these lesions, lift them away from the wall, and then use a insulated tip needle knife to dissect them out and remove them in their entirety. We are also working on a new technique similar to this, using a special scope which can move things just like a surgeon's hands in 3-dimensional fashion. So you can move it up or down, right or left, and we can grasp tissue and cut at the same time. And here's just an example in an animal model how this is done. We lift up the tissue, we can use the dissector and dissect, and just like a surgeon does intraoperatively, we are able to achieve this with this special scope called the R-scope, which we are working on at the current time.
Ram, somebody had a question about an earlier slide. What are the infection rates of those stents that you showed? A question by Dr. Dong Ball.
Yeah. So the infection rates are very small for the stents, and the reason is you're placing the stents in the lumen. In the lumen, there's already food going through, there's bacteria there, so the stents per se don't cause infection. Now, when you place a stent in the biliary tree, there is certainly a 1 to 2% incidence of cholangitis that can occur if adequate drainage is not established. But in the luminal stents, unless they perforate and penetrate into the peritoneal cavity, there really is not a high infection rate.
In a related question from Dr. Tretiak, there appears to be some barrier to the use of SEM stents for benign disease. How do you deal with that?
And some of that is rightfully. SEM stents is self-expanding metal stents, but for benign disease we were not using them previously because they were uncovered, and because in an uncovered SEM has the self-expanding stents, they can be tissue ingrowth, and then the stents will get locked into that area. But even with fully covered stents in the esophagus, we still have to be careful. We have to be careful because even though the tissue is not going to ingrow into the stent, it can overgrow. And one of the studies from Peter Siersma showed that indeed it can become quite difficult to retract them after 3 months. So that's why we are hesitant. Having said that, there are new stents that are being developed specifically for this, for benign disease. Some of them are biodegradable stents developed in the Czech Republic, and other fully covered stents which may come a little bit inside so that the hyperplastic ingrowth doesn't take place. Okay, so let's talk about an area which is a favorite of mine, is the endoscopic obesity management, and that's, I guess, in the stomach area. And one of the things that gastroenterologists and surgeons and innovators are working on is some way to do a primary therapy for obesity, whether it is by putting things in the stomach to fill up the stomach, whether it's by reducing the dimensions of the stomach, or by doing a bypass that's similar to the surgical bypass. So there are at least about 30 or 40 different companies working on different technologies that may allow this to happen. And I would predict that within the next 4 or 5 years, many of the surgical therapies that are going on now for obesity management may become obsolete, and there'll be much simpler, easier, safer, and almost equally effective therapies that will be available. So here is just an example of one technology called the TOGA procedure. This is an endoscopic stapling procedure which would go in, pull in the sides of the stomach and staple it to become smaller, or almost create the sleeve that can be that a surgeon does. Here's an example of something we have worked on, is to develop an endoscopic lap band procedure, go outside the stomach as shown in this diagram, and in the pig model below that, you can go outside, put a wire across, and then come and grab it from the other side, and then we can endoscopically tighten it to form a lap band. We still have a long ways to go before this becomes a reality. Another thing that's being developed is a esophago-jejunal sleeve. This is by a company called Valentex, where you would bypass the food contents from the stomach and the duodenum and the upper part of the small intestine, effectively creating a bypass. Another company that's actually much further along in this and have done human trials and actually have started a multi-center trial in the US is the GI Dynamics sleeve, which is anchored in the duodenum and bypasses the food all the way up into the intestine, so effectively creating a bypass. So you're going to see more and more of this as we move along. Moving now down to the small intestine. And one of the areas which are very difficult for us to visualize is obviously the small intestine. We can reach the stomach and the duodenum from above. We can reach the colon into the terminal ileum from below. But the whole area of the small intestine remains a black box. So for that, there are new technologies being developed, like this Spirus enteroscopy, and now this is being initially was a tube put on the scope, and the scope is pushed or pulled forward by rotation of the spiral as it telescopes the small intestine onto the scope. The newer version will be a scope that is dedicated with the spiral built onto the scope itself, which will then make its way all the way down into the small intestine and perhaps all the way up to the colon. So clearly the technology has advanced to reach that point.
We have a question here from Dr. Jose Martinez, and he'd like you to compare this spirus enteroscopy with the endoscopic capsule.
Absolutely. So endoscopic capsule in the diagnosis is still superior to spirus endoscopy. Spirus enteroscopy can get us up to the about the mid ileum, but not beyond that. It's very difficult to do it that way, and also has some trauma and some complication rates associated with that. While a capsule can go all the way to the end of the small bowel and actually has a very high pickup rate for lesions, especially with the newer capsules that are coming out. They're getting better and better. The problem with the capsule is that capsule, if it sees something, cannot cure it as yet, cannot fix it. And the advantage of the spirus enteroscopy is that you can reach there. If you can reach there, you can actually do therapies and cauterize and clip and close that
sample.
Sample. So let's move on to, since we are in the small bowel, let's see if we can go into the biliary tree. And I'll talk about two of the biggest advances that have taken place in ERCP in the last 10 years. One is the development of baby scopes, and this is one example of a baby scope that can be hooked onto the scope called the SPY scope, and then can be inserted into the bile duct to look at lesions. So instead of just injecting contrast to look at lesions, we can actually now go directly into the bile duct and the pancreatic duct and not just look at these lesions, but take directed biopsies from these lesions. Here's an example, and this video will also be on your website of a scope that we have helped develop also, which can go in there, but the imaging is even better quality with digital imaging, and we can even take the narrowband imaging into the biliary tree with this. We can even take a probe through the mini scope to enable us to do confocal microscopy. So not only can we go into the bile duct and the pancreatic duct, we can see the lesions, we can do microscopy to identify them even better, and this video is a very nice one to demonstrate that we had presented a few years back at our national meeting. But you can also take directed biopsies using this technique. The other area in ERCP which has been really hot for us in the last few years is the ability to remove large stones. And in the past, when we would see big stones like that impacting the bile duct, impacting the bile duct, we would have to do a large sphincterotomy. Then we would go in with different types of lithotripters. These are crushing devices that can mechanically crush the stones. We sometimes would take electrohydraulic lithotripsy to blast the stones, but it took a long time, but we would eventually be able to take them out. So what we started working on is a new technique where we do only a small sphincterotomy. It doesn't have to be a big sphincterotomy, and then use a large balloon to dilate it. And this has now been done by several groups around the world, showing its safety, effectiveness, and actually superiority in many cases to lithotripsy that we used to do. Also, this technology makes it a sort of an idiot-proof method in which, as we do a large sphincterotomy, the technical expertise of the operator becomes very important. However, when we do a small sphincterotomy and a large balloon dilation of that sphincter, we really don't need that much expertise to do it, and you are still able to accomplish as much or even more in our ability to remove these large stones. So this has been, in my opinion, one of the biggest new advances that have taken place in ERCPs, to remove these large stones without the need for lithotripsy by just making a small or medium-sized cut, but then stretching the whole rest of the sphincter out completely. And this is a very safe technique, very effective. The only point I'd like to make, if we do go with this technique, we just don't do the balloon sphincteroplasty without a sphincterotomy. The sphincterotomy is actually essential to decrease the incidence of pancreatitis when you use a balloon in the sphincter area. So very important to do the sphincterotomy, then the balloon dilation, and then we can literally take our hand inside and pull these stones up. So in conclusion, this is a very safe technique, the endoscopic sphincterotomy and removal. And also we have found that even if someone else had done the sphincterotomy before, we can do just the balloon dilation in that instance, as long as there has been a sphincterotomy, and remove big stones without major complications. This video, unfortunately, is also not playing, but will be on the website for you to see how this technique is done with the sphincterotomy followed by sphincteroplasty. Okay, so let's move on to the last area, that's the colon. And that's, again, an area of multiple new advances that have taken place. And actually, if I must say so, for primary care physicians, this is probably the most exciting thing. So one of the things that has happened, if you compare conventional endoscopy image on the left, previously we used to spray dye to be able to see better the flat polyps. And as we all know now that these flat polyps are the more dangerous kind of polyps, more likely to become cancers based on the recent data. Now we have the ability to visualize that by a technique called narrowband imaging, which really highlights, if you look at the left image and the middle image, it really highlights these adenomas much better, so we can find them and treat them. And I think this is now replacing, some form of this is replacing almost every center which uses colonoscopes. So different companies have different terms for it, but it's a specific wavelength that highlights these structures better. Here's another example of a hyperplastic polyp compared to an adenomatous polyp on the right, and you really can't make out on white light endoscopy. But when you do narrowband imaging, you can look at what we call the pit pattern and are able to identify the adenoma on the right and the hyperplastic polyp on the left.
Ram, are we familiar enough or confident enough with this to leave the hyperplastic polyp behind?
So Dr. Lamont is always thinking of cost effectiveness. And the question is that if you can detect them that accurately, why not leave the hyperplastic polyp behind, save on the pathology specimen being processed and stuff, and just take out the ones that are adenomatous? I think we are approaching that. In fact, there are studies that have been done on that, but we are not quite there as yet. I think once we use a combination of the narrowband imaging and perhaps the confocal microscopy on top of it, we may be able to reach that point, but we are just not there quite as yet. And just another example of another super high magnification scope, as you see over here. Okay, now gastroenterologists are frustrated surgeons, and all along we wanted to be surgeons, but got sidetracked into gastroenterology. And we are trying to take out larger and larger lesions endoscopically. Someday we'll be able to do this also, but not quite there as yet. And here is an example of a large polyp. And this is where, in the last 5 to 7 years, a huge amount of technology and technique has been refined, called endoscopic mucosal resection. And polyps like this is a 5-6 centimeter polyp, were unheard of, say, 7 years back, that we could remove them with an endoscope or a colonoscope. And now this is almost routine. In my own practice, probably 7 or 8 such polyps are sent to me every week for removal, and we are successful in upwards of 90% of these polyps. And here's an example of how we do this. You can see injection of a dilute methylene blue underneath the polyp to lift it away from the wall to create a safety margin for you. And once this is lifted up, we use special snares which are stiffer than the regular snares and push down on the cushion that we have created and are able to resect it. And this is only another 30-40 second video, Tom, if you will bear with me, to sort of show how this technology is used. But I would strongly encourage as internists that if you have somebody that has a polyp that has been found, the vast majority of these polyps we are now able to remove endoscopically, and perhaps sending them to a center which has the expertise, which many centers now do have that expertise to remove these large polyps without the need for surgery.
Is there a high risk of perforating the colon here?
There is definitely probably a 10 times increased risk when you remove large polyps like this compared to standard smaller polyps that are less than 2 centimeter. The biggest risk actually is not perforation. Interestingly, the biggest risk is bleeding, and the bleeding can occur either at the time of the removal, which we can control by putting a clip on it, but it can occur up to 10 days later. And that's the more important risk that we talk to our patients about. Perforations can occur, but by and large, once you create that cushion, we don't see the perforation. And even if we are suspecting a perforation, right at that point, we can put a clip on it here.
Does the patient go home after the polypectomy?
Yes. After the polypectomy, we don't keep the patients in the hospital. The patient goes home at the same time as just as a patient would go home after a standard colonoscopy and polypectomy.
So compared to a surgical operation, this has big advantages.
Big advantages, no question, and especially when you're talking about lesions in the rectum, which are actually much easier for us to remove, as we can remove up to 8, 9, 10, 11 centimeter polyps endoscopically, while in surgery, it would require a major AP resection. So especially in the rectum, it's a big advantage, but even across the entire colon, it's a big advantage, I would say. This is almost finished.
So we're good on time.
We're good on time.
Yeah.
Okay. Yeah. So this is what the area looks like. Once we remove a large polyp like this, it's important to go ahead and use a special, what we call a Roth net, to grab all the pieces, and these are all looked at by our pathologists very carefully. We follow these patients by bringing the patients back in 6 months to make sure there's no residual tissue, and if that's okay, then every 3-year follow-up is quite reasonable. Okay, so moving on to what's new, what else is new in colonoscopies, and one of the big things is the ability for, well, colonoscopy is a technique that's been there now, 40, 50 years. And is there a better way to look at the colon? I think that's been the challenge. And we know that virtual colonoscopy or CT colography really hasn't panned out. So there are different companies that are working at all different kinds of instruments that may make colonoscopy automated. And that's going to take away from people like you and me doing colonoscopies and making a living. And the companies that are there, some of them have moved on to other things: Invendo Medical, Sightline, Aeroglide, Neoglide, and of course wireless colonoscopy, which I'm going to definitely talk about. But these technologies are still in their infancy, but they're rapidly developing, and I'm absolutely certain that 1 or 2 of these technologies are going to gain steam and become mainstream. Here's an example of the Aeroglide, which is a scope that can be inserted in a primary care physician's office. The balloons are inflated, and it automatically guides the scope all the way to the cecum. But you can't do any therapeutics with it, so if you find something, you have to send the patient for a colonoscopy to take care of it.
So is the scope the white wire in the operator's hand?
That's the scope. So it's actually the tip as the camera. There's nothing else. The rest of it is the mechanism to move it forward. Here's another one that's actually even more interesting. This is a colonoscope which has a sheath on it, and this thing unfurls like a party streamer. So you blow on it, and or you don't blow on it, but there's a mechanism. It sort of unfurls, and by this unfurling is able to make its way all along the colon up to the cecum. But this has the ability to do biopsies, all the therapies that we do. This can do snare resections, biopsies. Everything that we do can be done with the scope. So you can have an assistant put the scope in and just make all the way across, and then as you pull back, you can do the therapies and look and do the therapies. Invendo Medical has published its first paper, 61 patients with a cecal intubation rate of 98.4%. Most importantly, only 3 patients required sedation. So that's really interesting that there may be a significant cost savings using this, because this can do it, you can do it without sedation, because it's able to make its way across without pushing, sort of just pulling its way across.
Ram, is that because the patients didn't have pain, or they ignored the pain?
Good question. Well, this was not done in the United States, so I don't know about our patients, but certainly in Israel, patients were able to tolerate this very well. Let's move on to the last group of 5 minutes that I'd like to talk about. What wireless capsule endoscopy, as we all know, is the state of the art to image the small intestine. But this company was not founded on that being the final goal for this technology. And they have been working over the last 15, 20 years now, or 15 years, on developing a capsule that may be able to look into the colon. And the first generation that they developed was really not adequate, even though the images were good, as you can see over here with the pill cam. Here are other images of the polyps, pedunculated polyps. The way they modified this capsule was they put 2 cameras, one on either side. So as it tumbles down the colon, at one time or the other, one camera will be able to see everything that's there in the colon. But even that, they had a 4 images per second frame rate, and the batteries were not that good. And the results were less than adequate, probably 50-60% sensitivity. But they didn't give up. And a couple of years back, they presented their data with PillCam 2, Colocam 2. And this was a prospective blinded multi-center trial in Europe of 117 patients. And what they were able to reach with this was a sensitivity of 84% for lesions that were greater than 6 millimeters, and 88% for lesions greater than 1 centimeter. And specificity was also quite good for lesions that were larger. So definitely in 4 or 5 years, it's made tremendous improvement by increasing the frame rate to 30 per second, by increasing the quality of the cameras that is there. And I think we're going to see more and more about this. This is very exciting. In fact, in Europe, this has now been approved for screening in some countries. In the US, we still have some reluctance to move in this direction. But it's a very interesting possibility. So the possibility is that you go to a CVS and buy a $174 capsule with a little thing that you can attach to your waist. You go home, you have to still prep, and then you swallow this capsule. The next day, you take your monitor that you were wearing and hook it up to the computer that Dr. Dumont has over here. And then you press a button, and these images will directly be transferred to Beijing, China, where there are gastroenterologists who would be working and being able to read this for 1/10 the price that Dr. Lamont and I would be charging in the United States. And overnight, they would send the report back to you in the US with the reading of your capsule endoscopy. And I can tell you one thing. All this technology exists as we are talking. All the technology that I'm talking about exists, and this will be possible. So for those of us as gastroenterologists who make a living out of doing daily colonoscopies, we have to really rethink what we'll be doing in the future. So this technology is making strides, and we are going to see more and more. So gastroenterologists will try and go beyond the lumen of the GI tract. And unfortunately, this video is not playing, but again, will be on the website. And this was the first endoscopic transgastric appendectomy performed by Dr. Rao and Dr. Reddy in India, where they went in through the patient's mouth, through the stomach with standard instrumentations, were able to locate an inflamed appendix, were able to put an endoloop around it, resect it, remove it, and close the opening of the stomach. And this was done. And since then, there have been several procedures such as this done for the appendix, for the gallbladder, and for oophorectomies. And there's a whole area of what's called NOTES, or non-surgical endoscopic procedures has been developed, and we are going to see more and more of that hopefully in the future. I'd like to thank you for your attention, and I'd love to take any questions that Dr. Lamont or you may have. Yes. Thank you.
Dr. Marilyn Roderick asked the following question. Can you elaborate on your statement that virtual colonoscopy has not panned out? Where do we stand with this? Are the radiologists in on the game?
So I'm sure you have some radiologists in the audience, but so the reason it hasn't, so when I say it hasn't panned out, if you look at the data on virtual colonoscopy, and I think, don't take me wrong, I think there is a role for virtual colonoscopy. There is a role for what's called CT colography. And the problem is that the sensitivity of the virtual test still has not reached the level of a good optical colonoscopy. So virtual's sensitivity still has not reached that level. Having said that, there are certainly some studies that have come out which have said that indeed it may have reached that level. So let's say that virtual colonoscopy has reached the level of a optical colonoscopy. The problem that is there is that you go ahead, get a virtual colonoscopy done, and you find something, the patient still has to come back in to get a screening colonoscopy done. So that is the limitation. It's an optical method that has good sensitivity. I still don't believe it's great sensitivity, but the gastroenterologist still has to go in and take care of that lesion. The other thing is that what has happened in the last 5 years is a much, much better understanding for us about what lesions in the colon are the most dangerous lesions. And the most dangerous lesions that we are finding now are what are called sessile serrated adenomas or flat polyps. And for these sessile serrated adenomas, they are so flat that even for us, it's more difficult to see these because they're just along the wall itself and you can barely detect them. And these are the ones most likely to become cancers. And I can bet that with virtual colonoscopies, there is not a chance that these can be picked up. And that's the biggest problem.
We have a couple of questions about training and who should be doing these procedures. Dr. Reinaldo Baron asks who would be suitable to do this, the gastroenterologist or the surgeon? And a related question on the training, how long does it take? And
I think both excellent questions, And I think at least in the United States, I can speak that the hands-on, the experience of a flexible endoscope or the mastery of a flexible endoscope is really important when you're doing these advanced procedures. The mastery of when you're removing these, large polyps and stuff. I presume you're asking about the large polyps or the notes procedure?
I think the more advanced procedures.
Okay, so let's talk about both of them.
Yeah.
So let's talk first about advanced polyps and large polyps. And I think a gastroenterologist is better able to do the flexible endoscopy so far compared to a surgeon. Having said that, when it comes down to the notes procedures, meaning going through the stomach and taking out the appendix and taking out the gallbladder, even though many of my colleagues may disagree with me, I think that's an area for surgeons who have endoscopic experience, because the surgeons truly understand when you're in the peritoneum, you're dissecting the appendix and you hit a vessel, what can happen in terms of if you pull too hard on the tissue over there. And that's something that we don't have experience with. So for notes procedures, I think it has to be surgeons who have good endoscopic training to do. For EMRs, large polyp resections, perhaps even POEM, the myotomy, I think the endoscopist would be a better person to do it, but an endoscopist who has knowledge of surgical anatomy, surgical principles, and has spent some time in the OR as a part of its training.
A related question by Dr. Catherine Miller. She'd like to know if a person has to be a specialist to provide some of these endoscopic procedures, or can specialists in general internal medicine or family practice or primary care physicians be able to do screening procedures?
Well, the way it's evolving, I think, especially if this capsule endoscopy in the next few years becomes a reality, and I can tell you if you take the slope of advancement of this technology of capsule endoscopy in the last 5 years, I think in the next 3 to 5 years, we are going to see a capsule, whether it's this capsule or another capsule, or then they're also working on capsules that can be placed even without a prep, and they have certain sonars that can look through stools at the wall of the colon. GE has been developing a capsule in Israel to enable that. So there may be technologies coming that we can't even comprehend. So I think as these technologies evolve, especially the capsule endoscopy technology and these scopes that become automated, so your dexterity doesn't matter, then it's a question of looking at the images. So if an internist has had the right training and knows what they're looking at, I don't see why he or she should not be able to do these procedures. I hate to say this, but I think that the evolution of technology may indeed make that possible. And we may go even beyond that. We may have a time when the computers can read these images, that the computerized will tell you whether this is a polyp or it's a hyperplastic polyp or it's an adenomatous polyp.
Well, I think there was a time when surgeons would be required to do many of the things you've shown us today. For example,
absolutely,
take out a big polyp. We have time for one more question from Gregory Nakopoulos. He'd like to know the recurrence rate of Barrett's esophagus after RFA, and is long-term medical therapy necessary in the final 45 seconds?
Okay, so our study, and I didn't show that slide, we followed the patients to 5 years. And at 5 years, in the 68 patients, we have after RFA, we had 92% of patients free of all Barrett's. So there was an 8% recurrence rate at 5 years for non-dysplastic Barrett's. That's the best we have long-term wise. I think this year, probably in a week's time at the DDW, there's more data that's going to be presented. But I would say at this point, for non-dysplastic Barrett's, the only data we have is the 8% recurrence after RFA at the end of 5 years.
Long-term medical therapy? Yes or no? That would be PPI after?
PPIs are so debatable. I mean, I can spend a whole talk on PPIs and Barrett's. But I would say probably not if the patient is asymptomatic.
Great. Thanks for a stimulating talk.
Thank you.
I would like to thank Shire, Viropharm Incorporated, UCB Inc., and Ferring Pharmaceuticals Inc. for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for the next session, Approach to the Patient with Abnormal Liver Function Studies by Dr. Nizam Afdal. My name is Dr. Tom Lamont. Thank you for joining us.